Hello and welcome to Talking General Practice, the podcast from GP Online. I'm Emma Bower, the editor of GP Online. Today on the podcast, I'm speaking to Professor Bola Owolabi, a practising GP in the Midlands and the Chief Inspector of Primary Care and Community Services at the Care Quality Commission, or the CQC. Bola took on this role in July last year at a particularly turbulent time for the regulator. In this conversation, she discusses how the CQC is working to turn things around after facing significant criticism about its work, the development of a new sector-specific assessment framework for primary care, and how she hopes inspections will become a less stressful experience for GPs, practice managers and the rest of the practice team. She also talks about her own experience of leading the turnaround of a GP practice in a deprived area that was rated inadequate by the CQC, the role of the CQC in improving care and tackling health inequalities, and how the regulator views the move towards neighbourhood health and the use of AI in general practice. If you're listening to this podcast, you know just how fast general practice is moving. To keep up, you need more than just headlines. A GP Online subscription gives you expert analysis on the latest news affecting general practice and how it impacts on you. A subscription to GP Online also gives you access to MIMS for prescribing information and MIMS Learning to help you complete your CPD. It's your daily briefing and your education platform in one. Subscribe now at GPonline.com. I'm delighted to be joined on the podcast now by Professor Bola Owolabi, a GP in the Midlands and the Chief Inspector of Primary Care and Community Services at the CQC, a role she took on in July last year. Before that, Bola was Director of the National Healthcare Inequalities Improvement Programme at NHS England, where she led the core 20+5 approach to tackling healthcare inequalities, which many GPs and primary care staff will be familiar with. Thank you for coming on the podcast, Bola.
Thank you for having me, Emma.
Before we get on to some of the specific questions about the CQC and some of the challenges general practice is facing, why did you want to take on this role at the Care Quality Commission? Your background's very much been around tackling healthcare inequality, so what was it attracted you to this role?
I've been very fortunate to have a very wide NHS experience in primary care, community services and acute and beyond. And so I think the attraction to the CQC is alignment. A very clear alignment between my personal vision of equitable access, excellent experience, and optimal outcomes for all, and the CQC's vision about making sure that people receive compassionate, high-quality care. And so there was that great alignment of visions that made it the place to be, and also the tremendous opportunity to make a genuine contribution to driving up the quality of care that patients receive. So for me, that's really the driver for joining the CQC.
There's been a lot of criticism of the CQC over the last year or so, and various reports outlining recommendations on how it needs to change and improve. I mean, just over a year ago, the final report from Penny Dash highlighted internal failings that were preventing the CQC from identifying poor performance and serious delays with publishing inspection reports. Some of those delays really affected GP practices as well. Have these problems been resolved now? How has the CQC turned things around?
So the first thing to say is on arriving at the CQC, I've been thrilled to meet some incredibly talented, committed people who, despite all of the challenges outlined in the Penny Dash, Mike Richards and Care Alliance reports, who are trying really hard to do the right thing. And what we've immediately done is we've embarked on a turnaround process, which includes a number of immediate actions, things that we can do here and now, and we're making significant progress in those things, as well as a number of things we call our foundational improvements. So in terms of the immediate actions, the CQC has appointed a team of chief inspectors with subject matter expertise. That's one of the key things in the Penny Dash report. And so all 4 chief inspectors are now in place, of which I'm one. Secondly, one of our key immediate actions was to address the stuck assessment. So these are inspections that had been done but not published, and we've pretty much eliminated the stuck assessments at this point in time. The other was to address the issue of the volume of inspections. And I'm really pleased to say that we are on track to deliver the target number of inspections set for us by the government by September 2026. So we are making significant strides in those immediate improvement actions. In terms of the foundational improvements, those are predominantly around our culture. And many of my GP colleagues have talked about their experience of inspections. And so we have undertaken a significant cultural transformation program where we're clear about our commitment to patients, to providers, and to the public. And we're on with that work as set out in our values. The other thing is the IT infrastructure. Many colleagues will know that we have had challenges in relation to our IT infrastructure. And again, we are starting to see the foundational improvements in that space as well. Lots to do, but a lot accomplished already.
GP practices tend to find CQC inspections very stressful experiences. They put a lot of pressure on GPs and the rest of the practice team, particularly practice managers. Because of this, over the years, local medical committees conferences have repeatedly called for the CQC inspection system to be scrapped or significantly overhauled. Why does an inspection put so much pressure on practices when they're already dealing with huge amounts of stress? What would you say to GPs and practice managers about this?
So as a GP myself, I recognize the pressure of the day job itself and what it takes to provide, excellent general practice to patients, and understand that even the anticipation of a CQC inspection can bring about a degree of pressure. But through this renewed approach that I've just been talking about, I'm determined to make sure that we get the balance right between the rigor of regulation, but being mindful of the context in which people are doing their work. And part of the things that we're doing is setting out clearly what does good look like, because this is not an exercise in catching people out. It's an exercise in affording colleagues the opportunity to demonstrate how day to day they are delivering that highest quality of care to their patients. And that's the intention. And so for me, my commitment is to make sure that our inspections, that they're contextual, they take the context into account, that they are proportionate by being cognizant of what the day job itself takes of GPs and GP practice colleagues, and also minimally distracting whilst ensuring rigor. I think all of these things need to come together in order for us to continue to build the trust and our credibility with my GP colleagues and GP practices across the country. So that's where we're headed. And I very much look forward to working with GPs across the country, the Royal College of GPs, and our other stakeholders, including the Institute of General Practice Management. I've met with them and we're together in this endeavour.
Okay, so how exactly is the inspection regime going to change? What will practices be expected to do under this new approach? Are the things that they're going to be measured against changed?
So first of all, I would like to say a big thank you to my GP colleagues because they responded in such a fulsome way to the assessment framework consultation that closed in December. So the assessment framework is really important because that is the methodology we use for our inspections. And so for us, it was really important that as we review, refine, and improve the assessment framework, we did so with the voices of the users, i.e., CQC colleagues, and the voices of those at the receiving end of the framework, GP providers. It was so important that we had their voices helping us shape the new assessment framework. So that's something that is going to be different, is that we're moving from what was a single assessment framework to frameworks that are specific to the sector. And again, that's something that came out loud and clear through the various reports. And so we launched a public consultation to help us refine our assessment framework to make sure that it's fit for purpose for the sector. And so that consultation has concluded, and we're continuing our engagement now with GPs through the RCGP, through the IGPM, through the Independent Healthcare Professionals Network, and others to shape what a sector-specific framework for primary care looks like. And that does include what good looks like. I'm looking forward to a time when we start to use the new sector-specific framework, and that's what people will feel in practice is different.
Do you have any timeframes for when that's going to be available for people to see?
At the moment, we're working through a very large volume of responses, which we welcome very much. We hope that sometime in the spring, we will begin to pilot and test the new approach, because what we want to make sure is we get it right. So it's not about the speed of the rollout, it's about the efficacy of the rollout. And so it's going to be a pilot test check approach, both with our providers and with our colleagues in the CQC, and then onto the full rollout once we're certain that the framework is responsive to the needs of the sector through the pilot phases.
And one of the things, obviously, that the previous regime, the inspection regime, relied a lot on data and things that the CQC would collect before an inspection. And the intention of that previous approach was to help the CQC identify places where there were problems. But obviously, as you've touched on, there's been quite a lot of question marks around the IT and the infrastructure within the CQC. Will you still be relying on all that data before you even go into a practice when you do an inspection? Or will that change as well under this new approach?
So the great thing about our GP practice inspections is, for the most part, they rely on the data held by the practice itself. So a key component of our GP inspections is the clinical searches. And that's literally the CQC looking at the practice's own data about the quality of care that they're providing for their patients. That will continue, because that's important, that the assessments we conduct are based in the real data. And so we will continue to do our clinical searches. It's also important as we go forward that we look at wider data. For example, all GPs across the country are aware of the various audits that are conducted. For example, the Cardiovascular Disease Prevent audit, CVD Prevent. And that is a powerful audit in that it tells us exactly how we are doing in terms of making sure we find out who has high blood pressure, managing that high blood pressure to the best extent that we can, and so on. I'm sure that my GP colleagues will agree that us relying on robust, validated audits as part of our quality assessment approaches is exactly the right thing to do. Of course, the IT needs work. When it comes to data, we do have a robust body of data, not simply that which is held by the CQC, but data that is held by other parts of the healthcare system that are reliable, that are validated and trustworthy. And we will continue to lessen the burden on GP practices through our inspection process by relying on insight from those validated and trusted data sources. For us at the CQC, addressing health inequalities needs to be threaded through the fabric of the way that we do our work in GP practices, but also how we use all our regulatory processes, all the way from registration, notification, inspection, enforcement. They're all very powerful tools that the CQC can use and will use, to address health inequalities. It's making sure that as we come out to do our inspections, that we are being insight informed and making sure that we have understood from the data what is really happening to that practice population, particularly the seldom heard, underserved parts of the practice population. So I just wanted to highlight that it's not just about regulation, but it's about regulation to drive up quality and regulation to narrow health inequalities.
Back in 2021, the CQC acknowledged that concerns that practices led by Black and ethnic minority GPs were more likely to have a poorer experience and poorer outcomes from regulation than those practices led by white GPs. How has the CQC addressed this, and do you feel confident that that issue has been resolved?
The CQC took this issue very seriously. It set up an entire body of work to look into the data to what extent this was the case. And what we found is that GPs from ethnic minority backgrounds, such as myself, tend to practice in areas of high socioeconomic deprivation, whereby people have multiple and complex health needs, as well as social circumstances that are often beyond the gift of a GP practice to resolve. And this does then translate into the challenges that the practice itself faces, which of course includes workforce recruitment. I led the turnaround of a failing GP practice in an ex-mining village with significant socioeconomic deprivation, and I know firsthand the difficulty of recruiting when you're working in those areas. And we found that there is a genuine correlation between ethnic minority-led GP practices and areas that are struggling from a poverty point of view. That impacts on the GPs, it impacts on their workforce, it impacts on their workload, and that can often then translate into difficulty in the quality of care that they're able to provide. That is what the data has shown us. And so what we need to do going forward is to make sure that we are reflecting that context in our narrative, in our reports. What patients will expect, though, is that the quality is maintained regardless of where you are. We can't have a postcode lottery of quality of care. But what we can do is take the context into account so that when we report our findings, we are acknowledging the circumstances in which the practice is operating. And so this is what the CQC has done. We looked at the data. We talked a lot to the GPs working in these areas. And if colleagues go online, you will see something called the Regulator Pioneers Fund. And it was a project that the CQC ran to actually look at quality improvement projects in some of these areas through a dedicated fund to support them. So that's the progress that we're making. There is still work to do in this space, but that's where we've gotten to. We understand what the issue is, and we have an idea of how we may be able to help. And I look forward to working with colleagues to help us continue to make progress in this space.
One of the problems, like you touched on there, is that a lot of these practices are in deprived areas. But the other thing that's kind of become more visible in recent years is that it's now widely recognised that practices in deprived areas are underfunded. You know, that's why the government's launched this review of the Cahill funding formula. Does that get taken into account, the fact that basically these practices are underfunded for the amount of work they do? How can the CQC reflect that in its inspection reports?
So the role of the CQC as an independent regulator is to protect patients. And it's really important that when we go and we do our practice inspections, that we focus on the quality of care that patients are receiving. That is the number one job of the CQC. I was fortunate to be asked by the Secretary of State for Health and Social Care to chair the work stream of the 10-year health plan that led on health equity. And one of our recommendations was the review of the funding formula. And I'm really pleased to see the consultation launched to address that. We look forward to the outcome of that. Going forward, in our narrative, we will describe the context in which GP practices are operating. And we must continue on behalf of patients to look at the quality of care that is being provided. The other thing that we do is to signpost others to where, despite these challenges, practices are managing to make significant progress. I gave you the example of the practice that I led the turnaround of in 2015, which at the time was rated inadequate by the CQC. We are still a socioeconomically deprived community, but the practice is now rated good across the board. It's a training practice, training nurses, GP registrars, and my hat off really to my colleagues at the practice who have made that happen. And so the job of the CQC is to signpost practices to others who are struggling similarly so that we can all learn from one another and continue to push forward on that shared purpose of high quality care for patients.
That's an amazing story that you've managed to turn that round from an inadequate practice into a good practice. How did you do that? What was the process you went through from starting at that point to inadequate to getting it to good?
I think it's always about the people. Every GP listening to me knows that we stand or fall on the quality of our people. And we were fortunate that although we had only a handful of practice staff, they were incredibly energetic, dedicated, and committed. The second thing is a wonderful patient participation group who understood the difficulty in which we found ourselves and supported and enabled us to expand the scope of our practice workforce. This was 2015, way before the days of the additional roles and so on. But through the patient participation group, we recruited a clinical pharmacist. We recruited emergency nurse practitioners, advanced nurse practitioners. Because of our challenged history, we found it difficult to attract GPs at the time. I was the only GP covering 2 branches, but the PPG supported us. GP colleagues saw the work that we were doing, and we started being able to attract GPs to come and join me. Start with the team that you have, enable them, value them, support them, work with your patient participation group, and also work with other practices in your area. I will never forget the many GP partners who came to do free sessions for us. It was the power of the community of practices in that area that enabled us. And I will also say, be brave. Sometimes you need to think about a new model. The truth is, we brought ourselves under the umbrella of a community provider trust. And that enabled me to focus on the clinical leadership of the practice, whilst the machinery of the trust was able to support us with the governance side of things. So think about your operating model, think about your people, think about your PPG, and use the power of other practices in your community.
That's really good advice. You've touched a bit on the workforce. We are facing lots of challenges with the GP workforce. How does that affect the quality of care that practices can provide?
We know across the NHS, not only in general practice, that we have a workforce challenge, and I'm really looking forward to the new workforce plan that is in development as we speak, particularly in terms of what it would say in relation to general practice. I have to say that we have seen through the data, particularly in terms of the additional roles, that multi-skilled approach to general practice. And when I've traveled across the country, I've had the opportunity of visiting many, many practices, including in my previous role at NHS England. And what I've found is that practices that operate in such a way where the GPs in that practice are, if I may use the term, they are consultants in primary care. They provide the ultimate clinical leadership. They're constantly upskilling the rest of the practice team so that everyone is operating at the top of their license. I find that that model helps to maintain a very high quality of service. I've been running something called Learning from Excellence visits, life visits, where I visit GP practices rated as outstanding by the CQC. And a common theme that I'm finding is this model that I've just described, where the practice, whatever the workforce mix happens to be, actually recognizes that its GPs are ultimately the clinical leads of that practice. They upskill the rest of the team. They enable people to work at the top of their license. They have very clear protocols that people work to. They have robust quality assurance mechanisms. They use the data. My practice visit 2 weeks ago, which was a virtual visit, they showed me in real time, they monitored their data in terms of patient access, people's experience, how they benchmark with other practices in their area, and they showed me the quality improvement projects that they had stood up in response to what the data was telling them. So it's that level of clinical leadership, wide scale mix, upskilling people, interrogating your data, putting in quality improvement initiatives. These are the things that our colleagues up and down the country are doing. That means that we're able to overcome the challenges that are there in terms of the workforce at this point in time.
There's a lot of variation in quality across the NHS, not just in primary care, but in secondary care as well, and variation in the experience that patients have. What can we do to address this? And what's the role of the CQC in helping to raise the standards so everybody is providing a good standard of care?
At the CQC, we do see significant inequalities and variation across the whole system. Primary care is no exception to that. We see inequalities in access, people's experience, the outcomes that they achieve, particularly for people living in areas of deprivation, older people, people from ethnic minority backgrounds. The role of the CQC in that is to make sure that we are encouraging primary care and the rest of the system to use those core 20 plus 5 approaches that were developed in NHS England. Because what it does is it focuses our energy. Primary care can't fix everything, but we do have a sphere of influence. And what core 20 plus 5 does is it defines precisely what that sphere of influence is. It tells us the core population groups that experience the greatest inequalities, and it tells us the clinical areas where we can make the most inroads in those inequalities. And so the job of the CQC when we go into practices is to remind colleagues that we already have a framework for action. The other thing that the CQC does is to use its independent voice to drive system change. So every year, the CQC lays in Parliament a document called the State of Care. The other thing that CQC does is to use its core regulatory processes. So the way we inspect practices, the way we're able to scale and spread good practice. So our job is not only to regulate, but also to be agents for improvement in narrowing the gap between the most and the least affluent and other populations that experience inequalities and unwarranted variation in care.
So do you see the CQC's role as very much helping to spread best practice as well as just regulating the sector?
Oh, absolutely. And the CQC does that already. If colleagues go on our website, in the reports, we will often mention, the key thing, why was that practice outstanding? I encourage colleagues to have a look at those reports because there will often be reference to a particular initiative or a project or something that a practice is doing that does contribute to them being good or outstanding. We may not be an improvement agency, we are a regulator, but we're absolutely agents for improvement.
Obviously, lots of GPs see CQC inspections quite negatively, but you did mention that they are an opportunity for practices to showcase what they're doing and what they're doing well. So when inspectors come into practices, how can they show the inspectors that they're delivering successful initiatives? What can they best do to showcase the innovations they've come up with?
One of the things that's really important is to see this as an opportunity to demonstrate what we're proud of, what we're doing well. We can change the mental framing of inspections to say, right, as a practice, we turn up day after day to do the best that we can for our patients. The CQC is coming to see that. And that immediately changes, I believe, the way we approach the inspection itself. So the documentation we provide, for example, we do the provider information request, the PIR, before we arrive. Put your examples there about the innovations, the projects, the things that you're doing that you want the CQC to be aware of and to see. When we're doing our clinical searches as well, make sure that all of the reviews of patients' medications, making sure that the long-term conditions have been reviewed and optimized, that's all visible It's really important. Organize it in such a way that it's easy to see it. It takes the pressure off you. It makes the work of the inspector so much easier. And there is always a conversation at the end of the day, as colleagues know. When the CQC has conducted its inspection, we sit down with the partners or the practice leads and have a conversation. That's another opportunity, to be able to say, by the way, in case you haven't picked it up until this point in this process, we would like to also mention. And again, people do have the opportunity to look at their draft report. That's another opportunity to say, I just want to also mention this particular project or initiative that we're proud of. But ultimately, let it be our business as usual. Equitable care is business as usual.
What does innovation in general practice mean to you? It doesn't necessarily mean having some groundbreaking thing that nobody's ever done before, does it?
Innovation, as you say, it's not about earth shattering things. It's about we looked at our data, we found these gaps in care for our patients, and we did something about it. Whether it's about variations in people's ability to access, for example, or the variations in people's experience. One of the practices that I talked to, it was about variation in cancer outcomes. They noticed from their data that actually it appears that people who are much more articulate, they get referred quicker on the cancer pathway than people who find it more difficult to express themselves. And so what they began to do was to train the practice staff, everyone, to spot the signs that may not be your barn door red flags that all of us know. They began to pick up those subtle signs. They encouraged reception staff. If you notice something different about Mrs. Joe Bloggs, mention it to the GP. They empowered all of the practice staff to say, all of us are the practice team, not just the GPs. And oftentimes, what they then found was it was the receptionists who were able to say, Mrs. Joe Bloggs has lost quite a bit of weight. And that can be the first pointer to say, oh, I'll check that when I see her. And they began to see that gap start to close in terms of the speed of referral of patients on the cancer pathway. That's the sort of story. Because we care, because we looked at our data, we spotted this difference. When we talk about innovation, it's about doing something that responds to the genuine needs of your patients, and it becomes your business as usual. That's what we're looking for.
Yeah.
And actually, one of the practices where I did a live visit recently, they have something called CQC Ready, whereby all of their work is organized under those domains of caring, responsive, effective, safe, well led. And so everything they do, they're constantly tracking back and saying, is this us being caring? Is this us being responsive? Are we using our resources effectively? And I thought that was a fantastic example of how we can consistently provide very high quality care as business as usual, so that actually the CQC coming is just an opportunity for us to say, here you go, this is what we're doing, and it's completely aligned to what you're looking for anyway. I thought that was a really neat way of running a GP practice.
There's a couple of questions I wanted to have about some forward-looking things. So firstly, about neighbourhood. So that's going to be a key change over the next few years. What sort of issues will the CQC be looking at in practices and partner organisations when it comes to neighbourhood working over the next couple of years?
So the truth about neighborhood is that it does move care closer to home and out of hospital where that is possible. As neighborhood health comes into play, you'll know that it's still shaping, it's still developing in many places across the country. Our view is that GPs are well placed to be a key player in understanding the needs of their patients, the needs of the local community, because we are the community. Many GPs either live in their communities or not very far away. And so when it comes to neighborhood health, we see GPs as being very well placed to play a key role in making sure that neighborhood health, however it's organized, understands and responds to the needs of that local community.
Yeah.
If we see neighborhood health as another innovation that helps us to be responsive, I think that would be a fantastic way of looking at it. It is a great opportunity to understand our local community, our populations.
There's going to be a big push on the NHS and general practice as well, specifically making better use of new technology over the next 10 years. How will the CQC be looking at how practices are making use of AI and tech during inspections? What will inspectors be expecting to see when they come round to a practice?
We know that AI, it does have the potential to benefit the delivery of care. What we will be interested in as the CQC is that the use of AI does align with our regulatory requirements and with good clinical governance. Because ultimately, we have to ensure that patient safety is not compromised in any way. The safety and compliance when it comes to healthcare delivery, that's there. That's really important. There are things that AI can do to help us in terms of the administrative burden, which we've talked a lot about in general practice. Whatever it can do to alleviate that, frees up the practice team to care, then that would be a good thing. And the other thing that I want to signpost colleagues to is that on our website, we actually have a GP myth buster about AI. It just tells you about how we will focus on systems and processes that just ensure that safety. As we use AI, we set out there what our inspectors will be looking for during an inspection to just make sure that the use of AI is supportive of, enabling of patient safety, high quality care, and being done in a way that is compliant with regulatory standards. So great potential, handle with care.
Thank you very much for your time today, Bola. I really appreciate you coming on the podcast. I know you're very busy.
Thank you, Emma. It's been a pleasure talking to you. Thanks for having me.
Well, that's it for this week. Thanks again to Bola and thanks for listening. I'll be back next week for our regular news review, so please do join me then. In the meantime, don't forget you can keep up to date with all the latest news affecting general practice and access a range of other resources on our website at GPonline.com.